afternoon or good morning to everyone. Thanks for joining us today on this fine and festive Friday. I'm Brian Birch. I'm a principal here at Eide. Been with the firm a little over 22 years. Spend most of my time in the regulatory reimbursement area, helping health systems, PPS hospitals, critical access hospitals, navigate the rules and regulations of CMS. Joining me today is Irina Zavina, and I'll let Irina do a little introduction.
Thanks, Brian. Hello, everyone. My name is Irina Zavina. I'm a senior manager at Eide, and I've been with the firm for a little over a year now. And prior to that, I worked for a large health system here in Colorado.
Thank you, Irina. Again, thanks everybody for joining us. Again, we're going to talk a lot about kind of regulatory review and compliance focused on reimbursement today. Talk about another opportunity, a lot of opportunities in the Medicare space, specifically some wage index and DISH, uncompensated care. Everything's changing, and this federal upcoming fiscal year is no different. So we'll touch a little bit on the IPPS and OPPS final and proposed rules. Again, trying to optimize your reimbursement, provide recommendations and strategies for you going forward, and also some reminders. With that, kind of here's the agenda or the objectives for today, some deadlines you should keep in mind, as I mentioned before, the OPPS proposed rule, the IPPS final rule, we'll touch base on those. And then Irina will spend some time with you in regards to these reimbursement updates and items there, and then finish up with some Medicaid DISH. So let's just jump right into it, as we only have an hour today. Could probably spend almost a full day on some of these topics. So with that, first off is upcoming CMS deadlines that we wanted to remind you of. If you are a facility that qualifies for the low volume payment adjustment, you need to have that request in by September 1st. Irina will go into a little bit more detail if you meet those, but again, more than 15 miles away from another PPS hospital and you have less than 3,800 total discharges. So please make sure you get those in by September 1st if you qualify for that. Geographic reclassification applications, your federal fiscal year 2021 applications to reclassify, or if you're withdrawing a current reclassification, are due to CMS by September 3rd. Again, make sure you allow enough time to get those in. Remember years ago, we had a client that actually flew theirs to Baltimore as they were late and it wouldn't get in, so they chartered a plane to get that in. That's a little extreme, but it meant a lot of dollars for them. Wage index for federal fiscal year 2021. So CMS will be reviewing the wage index coming up. So September 3rd is the deadline for you to request any revisions to your fiscal 17 data or your calendar year 2016 occupational mix. Based on the data that was published in the May 17th preliminary public use files. Again, we know that CMS is starting to, or your MACs are starting to review that, and all the desk reviews need to be completed by November 15th. So throughout this fall, you'll probably be hearing from your MACs in regards to their wage index desk reviews and requesting information and submitting adjustments. So any amendments to your S10 data for fiscal year 17 and 18 need to be in ASAP. Again, that's HCRAS data available through March, so they are looking at that, and I believe, from what I have heard, that CMS is starting audits on the 2017 cost report S10 data for PPS hospitals right now. So a number of the MACs are out auditing that data now. And then just as a reminder, review of the impact table and the supplemental data files published in the IPPS final rule August 1st to make sure that your data is correct that is in those. So that's just some deadlines there to remind you of. And going into the proposed rules, so the outpatient prospective payment system proposed rule was released on July 29th. Comments are due September 27th. It was officially published on August 9th. There's always a gap there from when they officially publish it and the release date. Here's just some links that you have regarding where you can find those. You can always find it on CMS's website. Sometimes it's a little hard to find on CMS's website, but you can find it there. The final rule for the outpatient prospective payment system will be published in early to mid-November is when they typically come out with that, and it's effective January 1st of 2020. So it is a calendar year rule for the outpatient side. So what was in it this year in the proposed rule, some highlights. There's a net increase of approximately 2.7% after the productivity adjustment. So that's what you can expect. However, if you're not meeting quality reporting standards, you'll have a 2% reduction in payments. So again, make sure we're doing the quality reporting and we're hitting those so that you get the full update of the 2.7%. Site neutrality, CMS is continuing on with their final year of transition for the payment reduction for accepted off-campus provider-based departments. This is on the G0463, so the clinic visit or outpatient site visit reduction. So they took most of those off-campus that weren't accepted have received 40% of the APC amount. CMS last fiscal year transitioned the G0463 for those that were accepted into a 2-year transition. So they reduced it of that 60% reduction, took 30% last year, and then the final 30% this year. So that will be done to get that 40% site-specific rate. 340B program cuts. CMS is continuing forward with the payment reduction minus 22.5% for 340B, with the exception for rural community hospitals, sole community hospitals, critical access hospitals, children's hospitals, cancer hospitals, et cetera, that are exempt from that. Even though it was ruled not in their favor that they shouldn't have done this, excuse me, CMS is continuing forward with it based on appeal. However, in the proposed rule, they are soliciting comments on the implications of a remedy that would put this back at what you were paid in ASP plus 3%. So they're looking at that. Probably the most hot topic that we're hearing about is CMS moving forward with more on the pricing transparency and asking you as hospitals, this would be all hospitals, critical access hospitals, DPS hospitals, inpatient psychiatric facilities, et cetera, to disclose payer-specific negotiated rates as Medicare or as CMS talks in the proposed rule. So proposing an expansion of what you're disclosing to patients on your websites to include charge and information based on negotiated rates with payers for common shoppable items and services in a manner that's consumer friendly. They do indicate that there's going to be penalties. Again, this is proposed. The penalty, I believe, was $300 a day for non-compliance. It's interesting that we're hearing, and I was on a call yesterday with the American Hospital Association and listening in. Obviously, they want to get feedback from you on this, the hospitals. But in this, CMS said that they indicate that it would only take 12 hours for hospitals to comply at an estimated cost of around $1,000. We all know that it's going to take much, much more. And so providing that feedback and comments, et cetera, as to how much time and effort it will take you to comply would be appreciated from the Hospital Association and others. The inpatient final rule was released August 2nd, published the 16th. There are some sites there. It is effective, as always, October 1 on the federal fiscal year of 2019. So what did it finally say? Inpatient payment rate update of about $3.8 billion estimated, or a 3% increase Actually, it comes out to about 3%. Well, when you factor in some adjustments, so the 3% update, less 0.4% multi-factor productivity adjustment, and then a 0.5% increase due to documentation and coding adjustment gets about the 3.1. Some other items in the final rule, S10, Factor 3, CMS is going to use fiscal year 2015 S10 data to calculate the uncompensated care for everybody. So if you have not seen that and you do qualify for uncompensated care, you might want to go out into the tables and see what that factor changed for your facility. Based on the proposed rule, CMS did consider using fiscal year 2017 instead of 15, but they settled on using that single year. This is a change of what they've done in the past. They did use 15, but it was a combination of both Medicaid days and S10 before, so it was a mix. Now it is solely using S10 for that from that 2015 year. Wage index, probably an interesting change here, or it is an interesting change here that CMS increased the wage index for hospitals that fell below the 25th percentile, which is 0.8457. So what they did is they increased it half of the difference between where that hospital's wage index was and that 0.8457. So all of those less than that 25th percentile did get a bump up in their wage index. That was because it's IPPS is budget neutral, then that increase in payments, estimated payments, was then spread to all other hospitals and through the operating standardized amount. Changes in the statutory rural floor calculation, so any urban hospitals that were reclassifying to rural and calculating each state's rural floor wage index is now going to be eliminated, so those reclassifications won't factor into calculating the rural floor. And then any hospital's wage index that was anticipated to go down or is going down in federal fiscal year 2019, if it's going down by more than a 5% amount, you are capped at a 5% decrease for all hospitals. So, and then that was applied through the budget neutral policy. And then new technology payments increase the maximum add-on from 50 to 65% for new technology for medical service and up to 75% for certain antimicrobial new technologies. So there was kind of a really fast run over of the OPPS rule and the inpatient PPS rule. Just one polling question, Amy, if you could start that, please.
Sure. Polling question number 1. Have you had any of your S10 data audited by your MAC?
All right, so of the participants today, which is a little above 40 that answered, only 5 of you, about 13%, have had the S10 data audited, so that's quite interesting. So again, it's not a large population that CMS, of hospital that CMS is auditing the data or the S10 data of, but if you're one of the lucky ones, then we'll work through it. So let's move forward, and Irina.
Thanks, Brian. Okay, so I wanted to mention we included a link to the tables and supplemental data published with the final rule a couple slides over it. We really encourage you to go in and recalculate your PPS rates and see what your Medicare reimbursement would look like. I know state hospital associations will provide those impact analysis for you. If you have any questions, you can certainly reach out to your reimbursement consultants as well. So let's talk a little bit about this. Costs associated with inpatient hospital services that are not paid on a prospective basis include costs incurred by hospitals seeing a disproportionate share of low-income patients. Now, most hospitals receive these add-on payments based on this primary method. They qualify based on the primary method. It's their Medicaid and Medicare fraction or the disproportionate patient percentage. Now, the ACA changed things up a bit, and effective fiscal year 14, instead of the amount CMS would otherwise pay to hospital hospitals' dish payments, CMS will now pay 25% of this old payment, and then the remainder will be paid to qualified hospital based on their share of uncompensated care costs. Now, simply put, you would have two parts of this new dish payment. You will calculate a portion of it, part one, consistent with the pre-ACA rules, and then it gets reduced by 75% on your cost report. So it will use a pretty complex dish formulas mandated by statute, and it includes the SSI ratio, the Medicare fraction, and the Medicaid fraction. The remainder, as I mentioned, will be in the form of this uncompensated care payment. It's important to keep in mind that hospitals must be eligible for this old dish payment first before they can qualify for the UC payment. I included a slide on this dish eligibility studies. Many of our clients invest a lot of resources in preparing those dish eligibility studies, typically a time of cost report filing, sometimes several months after, just to capture as many eligible Medicaid days as you possibly can to include into your calculation. Maybe not as relevant as these days used to be. Keep in mind that the total empirically justified dish, so this is that old 25% dish, is used to come up with the total uncompensated care pool, and because the pool calculation is not adjusted beyond the initial calculation, it is very important that we capture those, all of those eligible Medicaid days upfront on the as-filed cost report. Submitting additional Medicaid days through an amended or reopened cost report may not be as timely anymore under this new dish model. As you know, CMS will use the HCRIS data for the the uncompensated care calculation for the final rule based on whatever it's in HCRIS through March, the first quarter. So, okay, so this second part of the dish payment is the uncompensated care payment. It is a product of three factors. Factor one is the total unadjusted uncompensated care pool, which is basically that 75% of what dish would have been under this methodology. Again, this doesn't get updated beyond the initial calculations, so make sure you are capturing all those eligible Medicaid days on the as-filed cost report. Factor two reduces the total pool calculated in factor one based on the changes in the uninsured rate. So based on the final rule 2020, factor two is 67.14%, which reduced the uncompensated care pool down to 8.35 billion from 12.438 billion. Through fiscal year 19, there was also an additional reduction of 0.2 percentage points that it is no longer applicable based on the final 2020 rule. And finally, factor three, this is the particular hospital's piece of the pie. This is where S10 comes into play, specifically line 30 of S10 will be used to distribute, again, 8.35 billion in uncompensated care costs. Based on the proposed 2020 rule, CMS was considering, like Brian mentioned, using 2017 S10 schedule, but ultimately decided to go with 2015 since they have been through their review. Factor three increased by about 78 million compared to prior year. A little bit more about factor three. For fiscal year 19, it used 2 years of S10 data and 1 year of low income days. And again, for 20, based on this final rule, we'll just use 1 year, 2015. But in the comments, CMS did state that it may go back to using multiple years of uncompensated data in the future. So make sure that if you're staying on top of you're reviewing your data, if you're one of the lucky ones that is going through an audit, you're revising your S10s if you need to make revisions and you're able to support them through the audit. It is a zero-sum game, so the more uncompensated care a hospital provides compared to the rest of the qualified hospitals, the higher the UC payment will be. Here's just a little bit information about what's included in worksheet S10. Again, line 30 is the cost of charity care and plus cost of non-Medicare bad debt, the most important line on the S10 schedule. Now, for the purposes of dish reimbursement, the cost report at large is becoming more and more relevant for PPS hospitals, because even though there's only a handful of items creating a settlement through the cost report, the cost to charge ratio will be used on S10 to calculate the uncompensated care costs. So keep an eye on the overall cost to charge ratio, how it changes from year to year. If you see drastic drops, make sure that you are following up on those. So a couple of things as I'm wrapping up this section. Again, providers have until the end of this month reviewed the supplemental table and the information published with the final rule. We urge you to review this information and submit any corrections as needed. Again, if you are not currently under the 2017 S10 audit, you may want to kind of self-audit your data for 17 and 18 and amend your cost report if you need to make sure that you are ready for that review and you're maximizing your uncompensated care payment. During the audits, MACs have been asking for copies of charity and the financial assistance policy. They're asking for reconciliation of bad debts claimed on S10 compared to the financials. Of course, detailed listings of charity care and bad debts charges, and as well as payments to the level of detail that many of our providers are not able to produce at this time. They're also asking for the logic used to generate those listings, as well as descriptions of the hospital's transaction codes. And they're only giving us about 2-3 weeks at most to turn this data around. Now, MACs are saying that 17 audits so far are going much smoother. They're saying that challenges in 15 review have been resolved. The presentation is much cleaner. They're saying that they're collaborating with all the MACs are collaborating and they're talking to CMS. And there are some changes to the audit program. I did look at a request letter for the 17 audits, and they look very much the same as 15. If anything, I think most of the 15 audits focused on charity, whereas now they're focusing on the bad debts as well. And we are at the second polling question.
All right, our second polling question here. How is a total adjusted UC pool calculated?
So maybe our question was a bit, thanks Amy, a bit misleading, but we were asking for factor 2 for the adjusted pool. So it will be factor 1 times factor 2. So CMS will adjust hospital payments under IPPS using the area wage index to account for differences in wages among geographic areas. Keep in mind that the wage index is also used for the outpatient prospective payment system. So any changes to new policies will impact those payments as well. The wage index reflects the relative hospital wage level for each geographic area, and this average hourly wage is then compared to the national average hourly wage. The final 2020 rule made several very important wage index changes. Consistent with their focus on rural health, CMS, Brian mentioned that they increased the wage index factor for hospitals with a wage index value below the 25th percentile by 50% of the difference between that hospital's wage index and the 25th percentile wage index value. And this 25th percentile wage index value is 0.8457 wage index. So to calculate your wage index value, you would subtract your actual wage index factor from this 25th percentile, 0.8457. Take half of that and add it back to your original wage index value. Now, CMS insisted that this is done in a budget neutral manner. And in the proposed rule, they looked at paying for this by lowering the wage index for high wage index hospitals, or those above the 75th percentile. And ultimately, the final rule applied a budget neutrality adjustment to the national standardized amount for all hospitals. So now everybody is pitching in to cover for this policy change in a budget neutral manner. CMS also changed the rule floor calculation by eliminating the reclassification options of urban hospitals as rural. The rule floor, just as a reminder, the rule floor policy is that the wage index of an urban hospital in a state cannot be lower than the wage index of the rural area. And just to clarify, the hospital can still reclass from urban to rural, but CMS will just not use it in the calculation of the rule floor. And finally, to mitigate any drastic drops in wage index from 19 to fiscal year 20, CMS implemented this 5% cap on those decreases. And again, as a reminder, make sure you review the published file related to the wage index data. Any changes, any corrections we need to make need to be submitted by August 31st. As in the past, audits will start September 3rd, first working day of the next month for the max, and the completion of the audits is November 15th is the deadline. I wanted to briefly touch base on the occupational mix survey. Fiscal year 20 and 21 are using the 16 occupational mix deal. So please know that you still have time to review and make any corrections to that data. The purpose of the OCC mix is to adjust the average hourly wage to account for differences in your hospital staffing. So simply put, if you have a high mix of higher paid nurses like RNs, it will negatively impact your wage index factor. It is important that you review wage index every year and make changes as needed. As you know, it directly impacts your reimbursement. Things change. Busy with preparing the rest of the cost report, and wage index is the last schedule that we are completing, so we might feel rushed. We still have the second chance during the audit process to make any revisions to the wage index, so take this opportunity and make revisions if needed. Some of the areas to focus on as you review your wage index, of course, your payroll file, hours should be reported as paid, not worked. Make sure you're excluding hours that shouldn't be reported, like on-call or shift differentials. Focus on your contract labor. And one thing I wanted to mention here is we can be picky and choosy what to report as far as contract, and just focus on the large average hourly wage. We need to be consistent. If we can support the hours and the dollars, we should report it. And of course, spend some time looking at your wage-related costs as well. A couple of other reimbursement areas we wanted to look at. Brian mentioned the low volume payment. The requests are due to the MAC by September 1st. It is a pretty straightforward filing. So if you haven't done that already, it will not take you very long to complete. The Bipartisan Budget Act of 18 extended the temporary changes based on the ACA related to how hospitals qualify for this add-on payment. So therefore, through fiscal year 22, a hospital would qualify for a low volume hospital if it is more than 15 miles from another subsection D acute hospital and less than 3,800 total discharges. Geographic reclassifications in order to improve their wage index factor. Some hospitals who qualify to reclass from one CBSA to another. Applications are due no later than 13 months prior to the start of the fiscal year for which a reclassification is requested. So for fiscal year 21, it will be September 3rd. Once approved, these are effective for 3 years. So if you choose to withdraw after the first year or second year, you still have to notify them that you want to withdraw, and that's by September 3rd as well. In fiscal year 2020, based on the final rule, 859 hospitals benefited from these reclassifications, and 30 of these hospitals reclassified back to their locations. Another area of cost-based reimbursement is this allied health education. It is a separate funding from the Medicare GME program. MACs are scrutinizing this payment quite a bit in recent times. So as you're putting together your cost reports, keep in mind that you have to be able to prove that you are the provider. The program is a provider-operated residency program. You have to show that you have full control of the program, from administration of the program to running the day-to-day operations. You're in charge of both the clinical training and the classroom instructions. Make sure you are only claiming direct costs related to salaries of educators, stipends for your residents, and of course the overhead cost step down through the cost report. And make sure you're offsetting any tuition revenue that you have received for those programs. Also, in addition to this pass-through payment, there is another payment related to services to Medicare Advantage patients. And this has to be calculated and input on one of your settlement worksheets on your cost report. And we see several hospitals missing out on this reimbursement that they're due. So make sure that if you do qualify for this Medicare Advantage payment, that you do calculate it and include it on your worksheet E Part A on the cost report. Shifting gears to talk a little bit about the Medicare bad debts. I included this history slide here, and I won't spend too much time here, but reimbursement has been declining over the years. OIG has recommended that payments to providers be discontinued. And although CMS didn't take that recommendation, we continue to see Medicare bad debts on the OIG's work plan. And President Trump's most recent budget proposal included a reduction in the Medicare bad debt payment for some hospitals from 65 reimbursement down to 25. It is a pretty significant, it will be a pretty significant saving for them. This is based on the Congressional Budget Office, like $35.9 billion through year 29. I'll skip through the next few slides. They're basically the regulations around the Medicare bad debt. I wanted to keep them in here just so you have them as a reference, what's allowable, what's not allowable. But I wanted to bring your attention to some of the new requirements or clarification of a long-standing policy, as CMS would say. But on April 4th, CMS published this clarification reminder of their Medicare bad debt requirements. And basically they said that effective for cost reporting periods on or after October 1st, 2019, bad debts will be disallowed, Medicare bad debts will be disallowed, specifically as it relates to the crossover claims, if they were written off to a contractual allowance account instead of charging it off to an expense. Now, based on recent GAAP revenue recognition standards, it's my understanding that uncollectible accounts should be written off to a contractual allowance. And so there's a little bit of a discrepancy there, and we've been told that CMS is aware of that. And just as a reminder, it is just related to those crossover bad debts, so Medicare primary and Medicaid secondary. And of course, the last bullet point will not only impact your Medicare Bad Debt reimbursement, but it will also impact your uncompensated care through worksheet S10. This is just the guidance from the direct charge-off method based on the provider reimbursement manual. The reserve method will not result in an allowable bad debt expense under the Medicare program. And the direct charge-off method states that accounts deemed uncollectible should be charged off to an expense count. And we are at our third polling question.
All right, the next polling question here is a true or false. Final FY 2020 rule will increase wage index value for hospitals below 25th percentile by half of the difference between specific hospital wages index and 25 percentile wage index value across all hospitals.
Yes, this is true. All right, and I think Brian will take it over from here and talk a little bit about some of the additional items for Medicare cost report submissions.
Control here, I know I have it, Amy, but it just takes a little while. All right, so what we wanted to talk on now is this is actually back in the 2019 final rule, some additional items that you're going to have to submit when you with your Medicare cost report each year. And most of these items, well, in fact, all of these items are for cost report periods beginning on or after 10/1 of 18. Okay, so this was in arrears. So if you're a 9/30, September 30th year end, you will have to file this information going forward with this most recent year's 9/30/19 Medicare cost report. Everybody else would be after that, so within your next year end occurring. So June 30th year ends, not this fiscal year submission, but everybody else will be after that. So some items that Medicare is requiring you to send in and submit with your cost report is, as you may know, most of you are possibly uploading your cost report submission on the CMS portal now, so these items can be done with that too. But the first item is Medicare Bad Debt. So again, cost reports beginning on or after 10/1 of 18. If you're claiming Medicare Bad Debt reimbursement on your Medicare cost report, you must submit that Exhibit 2, that detailed bad debt listing that corresponds to the amount that's claimed on the Medicare's cost report. If it's different, Medicare could disallow the entire thing. But again, or if they don't, if you have these items on your cost report, but you do not have the submission in with it, they will reject your cost report. Which again, rejecting your cost report means it's a non-filed and non-timely cost report, of which your pay, typically Medicare will send you notification that your cost report's been rejected. And then if it's after the due date, then they will stop payment on any Medicare claims back to you until they received an acceptable cost report. So again, the Medicare Bad Debts, the Exhibit 2 would need to be uploaded with the cost report. Most facilities have done this in the past and just done their Medicare Bad Debt submission at the time of the cost report filing, but I know some facilities had not. But it will be required going forward. Another item is if you're a DISH eligible hospital, again, after the 10/1 cost report period beginning after 10/1 of 18, if you're claiming disproportionate share, you must submit the detailed listing of the Medicaid eligible days that corresponds to those days that you're claiming on your hospital cost report. So that listing will be required at the time you are filing your cost report. Again, if it is not submitted with it, your cost report will be rejected. If you, like most facilities, if you don't have the complete eligible days at the time of the cost report submission and you claim to, and you choose to submit an amended cost report later on down the line, then you must submit an amended listing or an addendum to the original listing that corresponds to the days that you're claiming on that amended cost report. So anytime that you're changing those days, you must submit an amended cost report along with the amended listing to go with that, otherwise it will be rejected also. One other item is your S10 data. So the charity care and uninsured discounts, that information that you're claiming on S10, those files, for those that are claiming this and DISH eligible hospitals, you must have the detailed listing of charity care or uninsured discounts that corresponds to the amounts that you're claiming on there. Essentially what CMS is after is that you have all this extra payment data that you uploaded at the time of the cost report filing, so that they have it and are available to audit that data at the time that you file the cost report. So again, this S10 data, the files that you're using to claim that data will need to be filed with the cost report upon submission. And then one last item is any of you have a home office that you're receiving home office cost allocations on. I'm not going to go through same fiscal year end and differing fiscal year end. You can read that, but essentially the home office cost report that you are using to show the related party allocations from the home office needs to be submitted with your cost report at the time of filing. Otherwise, again, your cost report will be rejected. So you must submit a copy of the home office cost report with your hospital cost report also at the time of filing. All right, I'll let Irina move on to the Medicaid DISH then and finish up with the last few topics here.
So finally, switching gears completely to talk about a couple of important topics related to Medicaid reimbursement. The next couple of slides are basically some general information basics around the Medicaid financing, and I certainly wouldn't go through those. I'm sure there's plenty of folks, I've looked at the list, and there are plenty of folks in the code that can school me about Medicaid financing, but we wanted to include it here just so we have it as just the starting point of our discussion. While some providers may be seeing Medicare payments go up a bit based on that final 2020 IPPS rule, Medicaid reimbursement and specifically Medicaid DISH funding is at risk. $4 billion in cuts are to go in effect October 1st, unless Congress decides to postpone those again. Another $8 billion of Medicaid DISH cuts are to go in effect the following year, and another 8 after that through fiscal year 2025. And although there's an overall agreement in Congress that these cuts will be disastrous for many providers who really rely on Medicaid DISH funding, it's pretty uncertain what's going to happen at this point. I've read the MACPAC report listing recommendations to Congress of how they should proceed in order to mitigate some of the impact to those DISH cuts. And there's several options. One of the options that they recommended was change the schedule of DISH reductions to $2 billion in fiscal year 20, $4 billion in fiscal year 21, go up to $6 billion in 22, and $8 billion in 23 through fiscal year 29. So the current law ends the reductions in fiscal year 25. This first proposal is extending it another 4 years. Another recommendation by the MACPAC is to apply a reduction to states with DISH allotments that are projected to be unspent. Go to those states first before applying to the other states. And then the third recommendation, which made the most sense to me, is to revise the state-specific DISH cap, since these were set based on historic DISH spending that's most likely inconsistent with today's low-income population in a particular state. To qualify for Medicaid DISH, providers can qualify either through the Medicaid inpatient utilization rate. It has to be greater than 1%. And as you know, many states have their own definitions that you should look into the state plan to find out of what the Medicaid inpatient utilization rate is. Many of them go to one standard deviation above the mean. Hospitals can also qualify based on this low income utilization rate, must be greater than 25%, And there's also an obstetrician's requirement. Hospitals must have 2 obstetricians with staff privileges at a hospital, and they have agreed to provide those non-emergency obstetric services to Medicaid patients. And keep in mind that if you're rural hospitals, those can be any physicians, not obstetricians specifically, with staff privileges who has agreed for non-emergency obstetric services. Coming down to the end, I think we have another polling question next.
All right, our last polling question. What type of funds are capped at the state level as well as a hospital level?
That's right, Medicaid is the correct answer. And one other thing we wanted to look at before we move to our Q&A session. As far as Medicaid dish reporting, there are generally 2 filing requirements hospitals should be aware of. There's one, a dish form, or here in Colorado we call it a data aggregation, that actually qualifies you for dish funds. And then there's the dish audit, or you will also hear it called a dish survey. The dish form, or the data aggregation that is used to qualify you, those are not audited. So typically the state will take whatever information you provide to them. They do some general review, compare maybe to your most recent finalized dish audit and see how uncompensated care costs compares. But those are not audits. And what we are finding is that many states are not providing specific instructions to providers of how to complete those forms. So, and again, they're used to come up with the Medicaid inpatient utilization rate and ultimately determine what hospitals will get Medicaid dish. We're finding that providers will report information on those forms pretty inconsistently. So our recommendation would be to take care of, as you're preparing those forms, to make sure that you're not jeopardizing first your dish dollars, and then that you are able to support those at time of audit. And also, if the state will provide available that information for all the hospitals used to come up with the mean and ultimately the 1 standard deviation above for that Medicaid inpatient utilization rate, request that information and review it to make sure that you agree. The dish audit, it is an audit. There are 2 surveys should be completed if hospital's year end is different from the state year. And those are the ones that will determine whether you get to keep the dish dollars that you've received in the past. A quick update on an appeal related to the Medicaid dish, FAQs 33 and 34, where providers were required to include third party, including Medicare payments in the calculation to come up with a hospital-specific Medicaid dish cap. I believe last week, the appeals court reversed the lower court's decision to exclude those payments. And we know that this will result in a significant payback to of these dollars for some hospitals. This is all we had for you. What questions we can answer for you?
All right, if you do have any questions, please use the Q&A box located on your menu bar, or you can use the chat feature. We currently don't have any questions right now, so if there's anything you would like to go over while we wait.
I really don't have anything else. Amy or Irina, do you have anything?
I can't think of anything. I know that we provided you with a lot of information about many topics. You have our contact information here. If you have any specific questions for us, please reach out to us. We'll be glad to, and we'll do our best to respond to your questions. But we appreciate your time today.
Awesome. Well, thank you all so much. And there's no questions right now, and I can see that people are dropping off. So everyone have a great weekend.